All right, it looks like we are live, and it's good to talk with you all today. I hope you're doing well. We're going to jump right in this particular session with this week in supervision is pretty much going to be based on, well, we're going to go over a couple test questions, but we're going to make this thing a reality. We're talking again. I like to talk a lot about and present to my supervisees subjects related to trauma and just how the mind and body work and how when the body is in conflict with the mind, how things just kind of show up and kind of get out of hand. And you may see these things going on as a clinician or someone that's looking from the outside in, but that doesn't always mean that the individual that is having that experience is aware of what's going on. That's the shocking thing. Even us as therapists, some things just seem so obvious, but many times they aren't. And so today we're going to be talking about the title is Your Body Knows What Your Mind is Still Protecting. All right. Your body knows what your mind is still protecting. And I'm going to go ahead and share my screen really quickly. And so that you can get a visual of some of what we're talking about. And we're going to start off with a video. We're not going to play the video, but in supervision, I like to play videos to kind of keep everything activated, keep everybody interested, allow them to kind of get into it. But this is a video by Jonathan Raskin, and we're going over primary versus secondary gain. Now, a lot of you all who are already licensed remember learning this or having on the exam, or some of you all that are in school remember these concepts. But what does this look like in real life? Because a lot of these concepts, we learn them, but then when it comes to the practical, where is that? And so there is reason why we know what we know, because there is roots to certain theories and things that we learn about. And so we're going to talk about that really quickly, right? So I'm going to start with this scenario here, and I'm going to see if you know where we're going. So here is the scenario. We're talking about Sue, and Sue is actually, if you watch the video, he talks about Sue in this video. Sue is a surgeon who develops significant who develops significant arm and leg pain shortly after one of her patients dies during surgery. The pain prevents her from operating and leads her to stop working. Medical evaluations do not fully explain the severity of her symptoms, but as a result, she goes on disability, and her mother comes to stay with her to help her at home. Sue reports the pain as real and distressing and does not appear to be exaggerating symptoms intentionally. Okay, which concept best explains Sue's presentation? Malingering, A; B, fictitious disorder; C, primary gain and second with secondary gain; or D, somatic symptom disorder without psychological factors. Okay, so what we have here is we have a surgeon who performed surgery and her patient died. So there is obviously, like in real life, there's obviously something that is going on in her mind that is disturbing. The thing is, the reality is, in most cases, surgeons, they experience these kinds of things, but they're able to move on. Okay, they're able to process and just move on. But in Sue's case, she's not able to move on. As a matter of fact, when she even thinks about going to surgery, or when it's time to do procedures and things like that, she cannot perform. She reports pain as being real and distressing. What do you think the answer is in this situation? And what I tell my supervisees is that, you know what, you don't always even have to know the answer, but sometimes just know what's not the answer. So in other words, if I know what the other three, and we try to study to learn what all four answers are. So if I know the other three and I'm saying no, none of those fit in with this scenario, then a lot of times we can find the answer. Also, I encourage you to stick with the script. Literally, the script that is here, stick with the script, because if you start adding things on, you'll miss it. Now, when it comes to psychotherapy, you've got to really think, because your client is relying on you to help them bring about resolution, and the things that you see many times aren't so obvious to them. So, let's ask the question. Would it be malingering? What is malingering? I have to know what malingering is to know that I need to X that out. And malingering is a situation where we're having symptoms come about that are faked. Okay, we're faking symptoms. Okay, we're faking symptoms. Usually, I believe this is a conscious awareness that we're faking symptoms. Okay. And so primarily we're faking symptoms in order to get some level of gain. So this might be that I don't end up having to go to work. I may be trying to get some type of monetary reward. So I am aware. I have an awareness that I'm faking symptoms with the goal of a reward. Does that sound like what we're seeing in this situation? This situation, Sue is all messed up because her client, her patient did not survive the procedures, and she's having difficulties moving forward because of pain. Pain. What type of pain is she having? Physical pain, emotional pain as well, right? Because sometimes we experience this at the same time. But that would not be it. Now, fictitious disorder. Fictitious disorder, what is fictitious disorder? All right. So, fictitious disorder is something that we experience when we're intentionally producing symptoms, right? We intentionally produce symptoms for a reason. So with these two, we can start trying to narrow things down. Does it look like that what's going on with Sue, that she's intentionally producing symptoms? Okay. Or is it something that just phenomenally happened and occurred? Okay. So intentional production of symptoms, I remember that from college. Intentional production of symptoms would be fictitious disorder. I like to look at fictitious as faking. You're faking symptoms with that F. Fictitious faking. But she's not at all faking symptoms. And we're not just faking symptoms, but we're faking symptoms with the goal of playing the sick role. In other words, you like that. All right, you have the goal of playing the sick role. And so in this case, that is not going to be the answer. Well, let's take a look at the other two. So we kind of look at these other two. We've eliminated two. And so let's look at somatic symptom disorder. Okay, somatic symptom disorder. What is that? Okay, somatic symptom disorder. Now, the thing is that with the other two, in most cases, we're not going to see any true symptoms. Okay, there is a production of symptoms. There are faking of symptoms, right? But with somatic disorder, guess what? A lot of times we do see symptoms. We do see symptoms. There's no intentionality in with these symptoms coming about. There is no rhyme or reason for it. They just come, right? So somatic, there's symptoms being produced. It's because of psychological things that are going on, but it's very different. These symptoms actually occur, and so we're going to skip past that one. We're going to skip past that one. And so right now we are left with only one option here. We're left with only one option here, and that is none other than primary gain and secondary gain. And we're going to take a look at that right now and get some more details about primary gain and secondary gain. Okay, so let's back up a little bit and go to a few of the notes. So the answer here is primary gain and secondary gain. Now, it's important for us to know what these are, because these are two very distinguished concepts. So in the situation, primary gain by definition we're experiencing the an unconscious psychological benefit. In other words, a person, it's an unconscious psychological benefit, something like anxiety or something that a person gets from developing symptoms. So some things can be so stressful that symptoms are naturally produced within the body because the body is overwhelmed, just doesn't really know how to handle it. That's what we're looking at with something like primary gain. The person is not consciously aware of the psychological conflict being avoided. Okay. So sometimes we avoid things and we're not very conscious. Our clients may not be very conscious that they're avoiding it, but they do. And that's because generally there is an unresolved something going on. We even see that like I've had clients that are raped or something like that in a certain location and so they become afraid of crowds or going into going into public places. Okay, so this is not necessarily a conscious thing all along. Sometimes they're avoiding situations where it's not even that crowded, but some way in their mind is giving them that effect. So this is kind of what we're looking at when there is unresolved conflict. Con- um, sometimes our actions will show that something is wrong. And that's where we have to make the determination and start using our therapy skills to find out exactly what that is when we're working with our clients. Okay. So that describes primary gain. The symptom develops to protect the person from emotional pain, anxiety, and things of that nature. So that's primary gain. But what about secondary gain? Because in this particular case, I believe it was speaking about Sue as a result having as a result of having to leave work, she gets on disability. Okay, her mother comes and stays with her, and Sue enjoys this. Sue enjoys this, right? She's happy to have her mother to come. I don't know that she's necessarily happy with disability because she was making much more money than that. But we have no evidence that shows that she intentionally allowed for this to happen. It's very obvious that this was not something that was conscious. The her having this pain and a somewhat an aversion to being in surgery or being in certain situations. She's going through a lot of distress. And so that is what we're getting here. And so the answer here, of course, is going to be primary gain with secondary gain. Okay. So we're going to go on to another question. And I wanted to piggyback a little bit on somatic disorder and kind of stress a little bit about how that works as well. Now, and why it's not somatic disorder. Sue's symptoms clearly function to manage emotional distress, indicating psychological involvement. This option minimizes the clear psychological trigger or trauma from the patient's death. Okay, so in this case, again, we recognize that semantic symptom disorder is not the answer. And what happens with semantic disorder is that you have symptoms being there's something that occurs where we see actual symptoms, but we can't find out where it's coming from. There is no true cause for the symptoms. Okay. And this is sometimes how the body works. Sometimes things happen in the body, experiences. I remember seeing someone who they thought that they were going to get married or something like that. And I don't know that this is what was occurring because this was not my client, but I noticed that they started having restlessness in their limbs. Okay, around the time that they had announced all this occurring, all these things were to happen as far as the marriage, and that's what they were saying, but the person duped them, and then they started having a physiological reaction. And if a client has a physiological reaction, when they think about something like that, when they think about what happened to them, when they're distressed about it, when they're talking about it, things like that, then in this situation, I didn't put this on here, that might be a conversion disorder. Okay, conversion disorder. So then I'm having symptoms that kind of somewhat look like a neurological condition because I'm going to the doctor and they're saying they can't find anything wrong, but then I'm having this disturbance where my leg is just moving involuntarily, or I might have some type of tremor on my face or something like that, and it occurs at certain times, or it could be ongoing, and many times it's a result of an unresolved, again we said, an unresolved conflict that we have experienced. And see, that's what they come to get worked out, but we've got to see it happen. A lot of times these things are unconscious. It's the body and the mind working on its own independently of our awareness, and as therapists we have to be able to point this out and and make it clear. All right, so we're going to move on to our last question here. See if you know the answer. A client consistently speaks positively about her father and denies, now this is based on a real life situation as well, um, speaks positively about her father and denies having any current relational conflict with him. However, when the possibility of traveling to visit him arises, she experienced panic attacks, headaches, gastrointestinal distress, and intense physiological arousal. She reports no conscious fear and insists she has worked through everything, despite acknowledging a history of childhood abuse by her father. Which concept best explains this presentation? So, the challenge for us as therapists is sometimes we have to do the emotional math. When you have had adverse experiences, many times the body is trying to protect, just like we talked about last week. The individuals who went through the ACE study, they start losing all this weight. The program was designed for them to lose the weight, okay? But then once they started losing the weight, they dropped out of the program. Why would they drop out of the program when they were there to lose weight and they hadn't achieved their full goal, but they were making great progress? Well, as we learned, is that they were getting unwanted attention. They weren't, it'd been so long for some of them since they had gotten that type of attention. They may have consciously forgotten or may have not been consciously aware that they put on all of this weight as a defense, unconscious, to keep people away so they wouldn't have to experience abuse again. This is how the mind works. This is how the mind works. And this is where we get into a lot of psychological problems. You're wondering why people are reacting in really negative situations, aggressive situations, when you think it's just something simple going on. I just said hello. Well, you sounded like somebody else when you said hello. Your tone when you said hello, the way your eyes look, the way that you're dressed, the way that you move, it may be a trigger to an unresolved situation. And so sometimes we see reactions. Somebody might get angry or something like that. But some reactions are larger than others, and that's what we're seeing in this particular situation. So we have to be able to sense that out. So on the table, we have malingering. So what did we learn about malingering? We learned that pretty much with malingering, we're faking symptoms. What we know about secondary gain, it's not always, it's not really the intent we can receive something, and it's kind of like a residual of experiencing something else, like what we saw with Sue end up having a secondary gain of being able to have her mother to come by to get the disability, but she didn't get sick because of that, or she didn't produce symptoms, intentionally produce symptoms because of that. And then of course with the primary gain, we talked about that, and we talked about fictitious disorder. Now in this situation, what do you think the answer is? What did you select? All right, so in this situation the answer is none other than C, primary gain. Okay, why is it primary gain? Why is it primary gain? Let's go back and look at the question again. We're talking about the same thing that we saw in the other situation. I try to challenge everybody with that because you might have thought, hey, we're going to have a different situation. I'm bringing the exact same situation, different context, different things going on. Like I said, this was based on a real life situation. You got to be able to put the math together. Like, you're having all this anxiety and panic attacks when you're about to go to this place. There's something wrong over there. and it may not be conscious. And our clients that have heavy trauma and dissociations and things like that often will have these types of experiences. All right, we're going to wrap this up. All right, so for this one, it is again primary gain. And the reason being is because, again, this is an unconscious psychological relief that this client is receiving. They're not, they're, their symptoms, the primary gain, of course, refers to the unconscious psychological relief. So it can seem like they're doing this on purpose, because like if you really know this person, if this is your brother or sister that's experiencing that, you really know that they put on like they have a great relationship with dad or mom, or in this situation dad, but it's not really that good. So you may consciously know that. Every time we're supposed to go on a trip to go home, then all of a sudden you're sick. All of a sudden we have to cancel plans. All of a sudden I gotta drive by myself because you're sick. Well, there is a reason behind that, and we start to process that in psychotherapy. I'm going to leave it right here. And just before I end, I do want to let you know about, for those of you all who are a part of Social Workers Alabama, we do